You still drive the Jeep?
I do. I still have the same car from when I was in residency. That's academic surgery for you. Thank you for that really kind introduction and warm welcome. It is really good to be back. It is a true privilege to return to where I was trained to deliver this year's annual Victor and Sigrid Gilbertsen lecture. I have no disclosures. In preparing for this talk, I thought about a lot of possible topics and meticulously stressed about it. But I landed on a very clinically focused discussion of the surgical management of melanoma past and present. And my hope is that this will be particularly helpful for the residents and students, while still being engaging enough to keep my former attendees from wondering why they ever invited me back. So any good surgical grand rounds will start with a little history. So here we go. Melanoma, also known as cancer noir or black cancer, was first described as a disease entity by René Laennec in 1806. However, it was actually Dr. William Norris who was really the first to study melanoma in depth, describing factors associated with the diagnosis and the clinical characteristics of the disease itself. He was also the first to advocate the surgical approach of a wide excision. And perhaps he was wise beyond his time because he recognized that surgery in the setting of disseminated disease provided no benefit. In almost 100 years later, we have Dr. William Hanley who stepped in and was actually the first to provide an understanding of how melanoma spread, which was via the lymphatic system. And it was this observation that drove his recommendations for the approach to a wide local excision, which include removing a vast majority of the subcutaneous tissue under the area of the primary, in addition to rather wide radial margins, as well as a lymph node dissection of the draining nodal basin. And this actually became the surgical treatment for melanoma for the next 50 years. And it wasn't until the 1960s with Breslow and Clark that we actually saw our next breakthrough in the treatment and management of melanoma. And this was actually based on their development of essentially the very first staging system, which was based on the thickness of the melanoma itself. With regards to Breslow thickness, this was simply the measurement in millimeters from the epidermis to the deepest penetration within the skin. For Clark and Clark level, this was about the extent of the downward invasion into the 5 different levels of the skin and subcutis. And what they saw was that the depth of invasion was predictive of recurrence, metastasis, and survival. The thicker or deeper the lesion, the higher the risk of recurrence, metastasis, and death. And so for the very first time, the door was opened for surgeons to ask the question, can we do less surgery in patients with lower risk melanoma and achieve the same outcomes? And this drove to first a number of retrospective studies, followed by a number of randomized controlled trials to see if we could more wisely choose a margin based on Breslow thickness of the primary melanoma. And what we found was that for every study except for one of these studies, there was no benefit to the wider margin. And so this led to the recommendations that we still ask you about routinely in the operating room for the margins for melanoma. For melanomas less than 1 millimeter thick, you need a 1 centimeter margin. For 1 to 2 millimeters thick, a 1 to 2 centimeter margin. And this is a result of those studies, that gap where we really didn't have an answer to this difference, the 1 versus 2 at this setting. And then greater than 2 millimeters, 2 centimeters is where you stop. There's never been a study that's shown better outcomes with greater than 2 centimeter margins. With regards to depth, of course, down to the fascia, or if it's an area where we don't have fascia, it may be peritoneum. No benefit in including the fascia in the resection unless there's clearly gross disease. Obviously, you need your negative margins. But we still had a question, so the 1 to 2 centimeter margin, and so we continued to work on this, and actually we are awaiting the results of the MELMAR-2 trial, which closed just recently, that actually is going to answer this question of 1 to 2 centimeter margins, not just for our 1 to 2 millimeter patients, but also for higher risk melanomas as well. So for surgical margins, we have definitely gotten wiser. But what about the surgical management of the nodes? As you recall, Hanley recommended a nodal dissection for the draining nodal basin in all of these patients. And there's really two definitions for this based on the clinical scenario. Elective nodal dissection is a lymph node dissection of the draining nodal basin in the setting of no clinically evident disease. While a therapeutic nodal dissection is the same nodal dissection, but it's in the setting of clinically evident disease. So you know that there's disease in that nodal basin that you're treating. Well, what's the big deal? We as surgeons like to operate. Why are we taking away one of probably my favorite cases, which is an inguinal lymph node dissection, until the patient recovers? And then I hate that operation because their leg looks like this. Not usually, but it can. And that is the lymphedema rates. We see rates as high as 50% in lower extremity lymph node dissections, 30 to 40% in upper extremity. Thankfully, we're getting better at managing this. We have preventive surgeries that we can leverage, but it's still a very dreaded complication that is long lasting for these patients. And that doesn't even include the sensory deficits that we can get from the injury to the superficial sensory nerves, the risk of motor nerve injury, wound infection, seroma, and lymphatic leak, which can be prolonged. And not only do we have those risks, we already knew from Breslow that actually for our lower risk melanomas, the patients that had a lymph node dissection did just as well as those who didn't. So what was the point of the operation? Well, I think it's about who benefits from nodal surgery. And it's probably not the patients without nodal disease. And I think that you have all heard this from people who have trained me, that we probably aren't helping patients by removing normal nodes. It is possible we might be helping patients when we actually remove nodal disease, so our therapeutic lymph node dissections are actually something we still do today. But can we identify those without nodal disease and avoid the elective lymph node dissection that we had routinely been doing? And the answer, as you all know, to this question is that yes, we can, thanks to Dr. Morton and his team who pioneered the sentinel lymph node biopsy procedure in the late 1980s, early 1990s. And so I know that you've all heard this before, but I can't drive home the importance of understanding this concept. So for the students here, I really want to make sure we explain this. The sentinel lymph node biopsy procedure is based on the ability to map the lymphatics and identify the node, the sentinel node, that drains that specific area of the body, whether it be breast for breast cancer or the skin for melanoma or skin cancers. I do this by injecting a radio tracer. We often will inject blue dye to help us identify the blue nodes in the operating room, but the radio tracer is what's going to show up on your imaging. And it will show you where the sentinel nodes are located. And it can be in more than one nodal basin, as imaged here, depending on the location of the primary lesion. We can then use the information from the images to make an incision over that nodal basin and identify those lymph nodes and remove them to be sent to pathology for complete pathologic assessment. And what Dr. Morton showed was that we could technically do this at fairly high rates. And like with any procedure in surgery, we surgeons got better at it the more we did it. And so he didn't only show it was technically possible, though. He also showed that there were a substantial number of patients that had no lymph node disease, and as such could be spared a lymph node dissection. In his series, 80% of patients. And so this confirmed the work of Breslow and Clark, showing that the thickness of the primary was in fact associated with the risk of nodal metastasis, and now we could actually find a way to spare those patients the additional morbidity of a surgery they didn't need. But we needed to test this, right? We want the data. So the multi-center selective lymphadenectomy trial 1, or MSLT1, was designed to compare sentinel lymph node biopsy versus observation in a randomized fashion in patients with melanoma that were clinically node negative and had a melanoma that was 1.2 to 3.5 millimeters thick. The patients randomized to sentinel lymph node biopsy. If they had a positive sentinel lymph node biopsy, went on to a completion lymph node dissection, meaning they removed the remainder of the lymph nodes in that nodal basin. The patients in observation group if they developed evident disease in the draining nodal basin, they were then taken for their therapeutic lymph node dissection at that time. So essentially a delayed lymph node dissection at the time of disease presentation in the nodes. And what this study showed was that there were about 16% of patients with sentinel lymph node metastasis. That's really close to the data that Dr. Morton had already identified. And that there was no difference in melanoma-specific survival between the randomized arms. So you could not improve survival between these two groups. It was the same. However, when you looked at the subgroup analysis of those patients who had a positive sentinel lymph node biopsy that got a completion lymph node dissection at the time that they were essentially randomized, compared to those patients we waited for lymph node metastasis to develop and then did their lymph node dissection, that group's survival, the delayed lymph node dissection survival group, was less. It was 52.4% compared to 72.3%. And so this shaped what we recommended for patients moving forward. We recommended they all get a sentinel lymph node biopsy, and if that node was positive, we took them to back to the operating room for a lymph node dissection. And while the thickness that we recommend sentinel lymph node biopsy on today is a little different from that initial study based on retrospective and prospective data that shows really we see kind of a steeper increase in the risk of lymph node metastasis at a 0.8 millimeter cutoff, we're doing things that are pretty similar to what we were doing on MSLT1 at that time when this study was coming out. Things have changed, we'll get there. So we were doing pretty well. So clinically node positive disease, they got their therapeutic lymph node dissection. Makes sense, we should remove disease. They were clinically node negative, they got a sentinel lymph node biopsy, and if the sentinel lymph node biopsy was negative, they were observed. If it was positive, they went on to lymph node dissection. So we were feeling pretty good, but we were still wondering if we could do better. And that was based on a number of studies, but particularly the intergroup melanoma surgical trial, which I want to point out was actually published about 6 years prior to MSLT1. And what this trial had done was randomize patients to elective lymph node dissection versus observation. And these patients had similarly clinically node negative disease and thickness melanoma, a little bit different but close, 1 to 4 millimeters thick. And what this showed was that there was no difference in survival between those who had an elective lymph node dissection and those who underwent observation. And so this was calling into question what we were seeing in the subgroup analysis on MSLT1. And MSLT1, they also saw where they were headed and actually had already started to design and open before they published the results of MS201 at the follow-up study, MSLT2. And so this study took those patients now that were in the positive sentinel lymph node biopsy group and randomized them to observation, which was really active surveillance. We monitored these patients with routine ultrasound to a completion lymph node dissection. So they're essentially randomizing the two groups they identified in the subgroup analysis. And the results of this study came out the very year that I graduated from the University of Minnesota. And I was, in fact, the fellow on the cutaneous service at Moffitt when this was published in the New England Journal of Medicine. And it changed everything overnight. This study showed that there was no difference in melanoma-specific survival between those who went on to a completion lymph node dissection versus active surveillance when they had a positive sentinel lymph node biopsy. We know in follow-up studies that there was a slight difference in disease-free survival with a p-value of 0.05, so right at that cutoff. And we certainly know that there was a higher risk of nodal recurrence in the observation arm, but that didn't translate into the melanoma-specific survival. And so what we saw happen was that it was supporting a previous study that came out of Europe, the DCOG study, that unfortunately was stopped short because it had such a low event rate. The time it would have taken to get to their preset recruitment was going to be so long they closed the trial. But what they showed for the data that they did have was that there was no difference in distant metastasis-free survival in those patients with a positive sentinel node who underwent observation versus completion lymph node dissection. So we have two randomized studies showing the same thing. And what we saw happen was probably one of the most rapid adoptions of data into practice that I personally had seen, we overnight saw a rapid drop in the number of completion lymph node dissections happening across the US based on NCDB analysis. So here's where we were with surgical management. We had gone from wide to narrow margins with the hopes of even more narrow margins to come once we have the results of Mark II. There was a dramatic decrease in lymph node dissections without worse survival, but we still had a little bit of a problem. Recurrence was still somewhat common, and 5-year overall survival rates for our higher risk patients left a little bit to be desired. And if you had disseminated disease, forget it. Prognosis was as bad as pancreas cancer. And the key reason for this was probably that we lacked a systemic therapy that was effective. Well, as you should know, this whole talk I said was about immunotherapy. So now we're going to get into it. And that is going to be the effective therapy that comes on the scene for melanoma that will change how we're doing surgery yet again for melanoma patients. And so if you look at the history we just covered as a timeline, you'll see that we've had surgical advancements that resulted in actually de-escalation surgery without effective therapy, except for 2 medications noted in red. Chemotherapy was all but useless, and these 2 medications were the foundation for the development of immunotherapy for treatment of melanoma, but these treatments left quite a bit to be desired, and we'll talk about that. So the first, interferon alpha 2b, was the first one to come on the scene and published in 1996 after a randomized controlled trial that looked at stage 2b and 3 patients who were treated with surgery first and compared compared delivery of interferon versus placebo. And what we saw is that there was, in fact, an improvement in relapse-free survival and overall survival for these patients. And I think what's important is how you see this line flatten out and keep going. And that's a sign of the durable response that immunotherapy was able to provide, which was unique compared to other agents like chemotherapy at that time. However, the problem was this medication was not well tolerated. There were patients dying from the treatment itself. It had to be delivered in the ICU. It wasn't able to be given in a lot of centers. So it wasn't exactly what we were looking for. Next came high-dose IL-2, and multiple studies looked at this agent. And in this meta-analysis of 8 clinical trials for patients who received this for unresectable metastatic melanoma, so a different group, but a stage 4 group essentially, there was a 16% overall response rate. Not exactly great, but what you can see is in those patients who had a complete response, that top line, they responded and stayed alive for years. They did very, very well. And so if you happen to be one of those responders, it was great. But the vast majority of patients didn't respond. And again, the toxicities for this medication, not a whole lot better. And so it really wasn't until 2010 to now that we saw the huge change in the systemic therapy options for melanoma. And these came in the forms of checkpoint inhibitors, targeted therapies, oncolytic viruses, and now cell therapies such as TIL. For the purpose, though, of this talk, we're going to focus on immunotherapy and cellular therapies. Otherwise, we'll be here till tomorrow. So what is immunotherapy? Immunotherapy is a treatment that works to upregulate the immune system to recognize and kill cancer cells. In the case of medications like pembrolizumab, they do this by blocking the PD-1 receptor on the T cell from binding to PD-L1 on the tumor cell, preventing the deactivation of the tumor cells that the cancer normally causes, increasing the T cell's ability to recognize the cancer cell and orchestrate an immune attack against the cancer. And like any therapy in a cancer that's new, it starts in our most advanced patients. So we saw a number of studies on a number of agents in our advanced patients or advanced disease patients that showed the effectiveness of these medications and that they were generally well tolerated. These are outpatient medications that were able to be given. Patients generally completed their course. And so it was a huge step forward from what we previously had. And so when we had medications that were working in our advanced stage disease, we immediately wanted to know, could we leverage the same benefit in an adjuvant setting for our patients that were amenable to surgery, so our local regional disease patients. And the first of these studies and medications was ipilimumab, which we'll call IPI. And what they did was they took patients with stage 3 melanoma who underwent complete resection and compared it to placebo in the adjuvant setting. And what they saw was an improvement in recurrence-free survival and eventually overall survival compared to placebo. There were a significant number of adverse events, 54%, which is kind of what you expect for IPI still today. But it was, again, something that could be delivered on an outpatient basis. The next on the scene was nivolumab, and this was actually a head-to-head comparison of nivolumab versus ipilimumab. And they took stage 3B, C, or 4 patients that were amenable to complete resection, underwent complete resection, and then randomized them to nivolumab versus ipilimumab. And what they saw was that actually the recurrence-free survival was better for the nivo group, and the adverse event rate was significantly lower in the nivo group as well. So this was a huge win, and we started to see a shift in the medications that we were leveraging. And then finally, pembrolizumab on the scene next. Very similar randomized control trial, however, back to comparison to placebo. And we have yet to really have that head-to-head comparison of pembro versus nivo, and I don't think that the drug companies are ever going to have that happen. But what it showed was that very similar to nivo, it had a good recurrence-free survival compared to placebo, and a very similar adverse event profile to nivo as well. And so in basically a decade, we had gone from having essentially no systemic therapy to multiple immunotherapy options. And this doesn't even include the targeted therapies that were coming on the scene at exactly the same time. And so I know that the last thing anyone wants to come to Grand Rounds to hear about is a medical oncology talk, but it's really, really important because these trials change how we're treating melanoma. And because this changed, the surgeons have to understand that, because the type of patients that you're going to see them first. And so you have to know who needs to see medical oncology after you. So in our patients with stage 1 and 2 melanoma, they're going to get their wide excision plus or minus their sentinel node based on the T stage. And then based on the sentinel lymph node results, you need to know if they need immunotherapy, because these patients in these studies were all stage 3. So anyone with positive nodes needs to move on to medical oncology for a conversation of immunotherapy, but they get to avoid their completion lymph node dissection. If they're presenting with stage 3 melanoma, you start with your wide excision, your lymph node dissection, and then send them to immunotherapy. If the surgeon doesn't know, the patient doesn't get this additional line of therapy that we have to offer them the first time. Just like anything with this talk, each time we're like, can we get a little bit more? Can we get a little bit more? So we know that the staging system in melanoma is not perfect. Our stage 3A patients tend to actually do better than our stage 2B, 2C patients. This is a failure of the staging system, but it is what it is right now. And so the question was, can we improve the survival of this subgroup with adjuvant immunotherapy? Same question that we asked with the stage 3 patients. And so pembrolizumab was the first drug to publish on this. And what it showed is that in our stage 2B, 2C melanoma patients who had a wide excision plus a sentinel lymph node biopsy, pembro versus placebo resulted in a improved recurrence-free survival for pembro compared to placebo, and similar adverse event rates to what we saw in our other trials. We're still waiting for this data to mature to see if this results in an overall survival. We're not there yet. Not wanting to be left out, nivolumab ran a very, very similar study. Again, stage 2B, 2C melanoma patients, complete resection, including a sentinel lymph node biopsy, nivo versus placebo. Again, see that no pembro-nivo comparison. And recurrence-free survival, again, improved, awaiting for the results as far as overall survival and adverse event rates similar to what we would expect for this medication. And so now we have another group of patients as surgeons that we have to remember can be candidates for immunotherapy and need a consultation with medical oncology after our surgery. It's not just those with positive nodes anymore, it's patients with thicker ulcerated melanomas that we need to consider this for. But I think this has begged the question and is going to be an ongoing question, which is why even proceed with a sentinel lymph node biopsy in stage 2B or 2C melanoma patients if they're going to get immunotherapy anyways? What's the point? Well, we've not really had a study looking at this, and we're probably never going to have a randomized controlled trial comparing this question. But I think there are a few things to think about with why we are generally still proceeding with this procedure for most 2B, 2C patients. The first is that some people think that there's a benefit to the sentinel lymph node biopsy that's actually therapeutic and not just staging. They point to the MSLT2 trial results for this, saying that 80% of those patients in the observation arm didn't have a nodal recurrence. And so the sentinel lymph node biopsy removed the disease that needed to be removed, and it was a therapeutic sentinel lymph node biopsy. I think we can spend a lot of time going back and forth on that, and there's been some position papers written about that, but that's one consideration. The other consideration is for prognostic information. We know that lymph node status is the strongest predictor of outcomes. This is an ABSITE question. I remember it. So this is the strongest predictor of outcomes in patients with local regional disease. So having that information can help us talk to patients about what we expect and maybe help tailor the use of adjuvant therapy. We're still waiting to see if there's a clear overall survival benefit for 2B, 2C patients with adjuvant immunotherapy. We know there is in stage 3. So if someone's older, sicker, maybe not going to tolerate the therapy well, maybe knowing for sure their lymph nodes are not involved helps you say, you know, the absolute benefit of immunotherapy in your case might not be as profound as if you had lymph node disease. But then there's the counters to these thoughts on why we should still do sentinel lymph node biopsy. And one of those counters is that actually, are we missing an opportunity to de-escalate surgery further in this population? Because if we don't have to do a sentinel lymph node biopsy to determine what adjuvant therapy someone's going to get, we can avoid a trip to the operating room and the anesthesia associated with it. You can do a wide excision in the clinic under local. You don't need general anesthesia for that. You generally need it for sentinel lymph node biopsy. At least I would personally want it for my sentinel node biopsy. And so we could take this opportunity and maybe de-escalate surgical care further for a certain population that might otherwise be poor surgical candidates. But maybe the biology is what should drive us and why we do this. And I think people much smarter than myself have brought this up a number of times, which is why remove the key component of the immune system when we're relying on that very immune system to fight the cancer when using immunotherapy? And wouldn't immunotherapy work better if there's disease in place for it to recognize and then fight, and you have an intact immune system with all lymph nodes in place? And it's actually some of that biology and question that has been driving the next change we've seen in the role of immunotherapy, which has impacted our surgical care, which is the use of immunotherapy in the neoadjuvant setting. And so outside of the biology for the rationale for using neoadjuvant immunotherapy, there's also the benefits we talk about for other disease sites. So the ability to monitor a therapy response because you actually have tumor in vivo to monitor. The ability to tailor your adjuvant therapy based on response, because you can now look at your surgical specimen and say, oh, it's all gone. I don't need to give more treatment. Or maybe it's still there. We need to give more treatment. And then it also provides us further opportunities for surgical de-escalation. And so the first study that published on this was the SWOG S1801. And what they did was they took patients with resectable stage 3B through 4 clinically accessible melanoma, meaning there were lesions that you could actually monitor either in the exam room or on CT. And they randomized to either receive pembrolizumab for 3 cycles, followed by surgery, followed by another 15 cycles of pembrolizumab, versus surgery first, followed by 18 cycles of pembrolizumab. So both groups are getting the same number of cycles, but they're getting them at different times. And the primary endpoint for this study was event-free survival, defined as time from randomization to first progression or toxicity preventing surgery, right? Because we don't want to lose our surgical window, to no adjuvant therapy within 84 days of surgery. Now, because of surgery, they weren't able to get their adjuvant therapy, and post-surgery melanoma recurrence or death. And what they saw was that the event-free survival was significantly better for those patients who got the neoadjuvant approach compared to the adjuvant-only approach. And the adverse event rate was not significantly different between the two groups. as to the pattern you've seen, of course, Nevo didn't want to be left out. And so they actually did a couple other trials that led up to this. But I know at this point, we've talked about 8 medical oncology trials, so I'm trying to focus in. The Nadina trial. This trial was actually a fairly cool study design because it took patients and randomized them to neoadjuvant therapy with tailored adjuvant therapy, compared to randomizing to surgery first and then just standard adjuvant therapy, kind of no tailoring there. And so in the patients who got neoadjuvant therapy, they got 2 cycles of Ipi-Nivo, a combination therapy, then got surgery. In those with a major pathologic response, they got no further treatment. In those who had only a partial response or no response, they either got additional nivolumab, or if they were BRAF mutated, they actually switched to a BRAF MEK inhibitor and got that as their adjuvant therapy, compared to the patients who had surgery first and then just went on to adjuvant nivolumab. The primary endpoint for this study was also event-free survival. And similarly, we saw an improved event-free survival for those patients who had neoadjuvant therapy compared to adjuvant. Our adverse events rate was more than what we saw in our Pembro study, but what we expected for all the other studies for ipilimumab in the adjuvant setting. That medication is just one of those medications that's going to come with adverse events. And so we went, again, almost overnight. This was actually 2 years into my attendinghood at Kentucky, and I remember seeing a patient the day before and recommending going to surgery, and the next day we were offering upfront immunotherapy. It happened that quickly. And so we took this patient group down at the bottom from a wide excision and lymph node dissection followed by immunotherapy, and we're now prescribing immunotherapy first. But like with any advancement, it only raised more questions. So what surgery do you do after neoadjuvant immunotherapy in clinical stage 3 melanoma? What are the margins for the wide excision? All of those trials we talked about that gives you the answer to the question on the test about your margins were done before immunotherapy was even a thing, and so certainly wasn't incorporated into those margin studies. Should you do a lymph node dissection or a sentinel lymph node biopsy? In breast, we went to sentinel lymph node biopsy after neoadjuvant chemotherapy and now immunotherapy too. Or can we tag the node and remove just that node, calling it the index lymph node, and make decisions about treatment based on what happened in that index lymph node? Well, if you go to the NCCN guidelines, they seem to be equally confused about exactly what we should recommend. Because it says, all right, so if you give them neoadjuvant systemic therapy, wide excision of the primary tumor, we go to principles of surgical management and click on principles of surgical management, and it is the exact same margins that I had shown earlier in the talk. Okay. And then they say, well, yeah, you should definitely do the therapeutic lymph node dissection because that's the standard of care. But, well, there are studies ongoing that look at if we can maybe do an index node removal and we can figure that out. So not 100% clear. We'll make it simple. For your boards, you are stuck with a lymph node dissection right now. For the wide excision, I think they're probably going to give you a little more grace because everyone's going to say, well, taking a wider excision in the setting of lymph node disease probably doesn't make a whole lot of sense. Get it out with negative margins. And so what data do we have that's kind of pushing this next step? And that comes from the Prado study, which was a subset of patients in the opposite neo trial that led to the Nadina trial. So what this sub-study did was it took patients with stage 3 BC melanoma and put them in the group that got Ipi-Nivo first, and then they resected the index node. So the node that they had biopsied to prove disease, they left a clip in it. Then they went back and they removed that lymph node with the clip. And then they gave additional surgical and medication therapy based on what was going on in the index lymph node. And so for those who had what they considered a major pathologic response, those patients got no therapeutic lymph node dissection and no adjuvant therapy. For those that had a partial response, they got additional surgery, but no additional adjuvant systemic therapy. For those that had what they considered essentially a non-response, they got surgery plus medication. Again, with the caveat that if you were BRAF mutated, you got a BRAF inhibitor, and if you weren't, you continued with nivolumab. And what they saw was that first, we actually could remove the index lymph node pretty reliably. So the vast majority of patients, we were able to find the index node and remove it. There was quite a bit of path response. 72% showed some sort of response with a fairly high number of complete response. And the survival in those who had a pathologic complete response in that green line was exceptionally good, despite the fact that they had not gotten additional surgery and had not gotten additional adjuvant therapy. But the trouble is this study had 99 patients. Actually, only 90 went on to removal of the index nodes. So it was small and it wasn't exactly powered to look at the survival outcomes. And so now we're waiting for the next study that will tell us what we, I think, are probably expecting, which is that this index node approach is going to work and should be adopted. We'll see. But that's the MSLT3 study. So I think we will be on to that soon. It's already open in some countries. The SWOG group is waiting for some regulatory things to push through to open it here in the US, and we're getting closer though. So what is my general approach to the surgical management of patients with stage 3 melanoma after neoadjuvant therapy today? Wide excision of the primary site. I tend to use a narrower margin. It is generally a lymph node dissection still. However, we have started to slowly start leveraging the Prado data with select patients getting an index node removal and additional therapy based on that. But we're looking forward to enrolling to MSLT3 in the near future. All right, so this is a time where like shake your neighbor, wake them up, because this is the most important part of the talk for you all and hopefully makes it worth it. I'm hoping the context and the historical framework helps you actually remember this, but if not, here is what you need to know. For patients with clinical stage 1 to 2A melanoma, they need a wide excision plus or minus a sentinel lymph node biopsy based on T stage. If the sentinel lymph node is negative, they get surveillance. If the sentinel lymph node is positive, they get immunotherapy, not additional surgery. If they're presenting with stage 2B, 2C melanoma, they get a wide excision, generally with sentinel lymph node biopsy, at least today, but it is a discussion point that I often have with our medical oncologists. And then if the sentinel node is negative, they get immunotherapy. If the sentinel node is positive, they get immunotherapy. And then for patients presenting with clinical stage 3 disease, they're going to get immunotherapy first, and for now, a wide excision and lymph node dissection. So the only group we haven't talked about is stage 4 disease. So what is the role of the surgeon in stage 4 disease? Historical data showing favorable outcomes for metastasectomy have always been there. They're retrospective series, prospective series, highly selected patients, subject to selection bias. And so it's something that's pursued generally in a very selective setting. However, there's quite a bit of renewed interest and consideration for this now with modern effective therapy. But again, the data is still in that kind of same framework. Prospective series, retrospective series, hard to know who is the right person to select for something like that. But thanks to the development of new cell therapies, we actually have an entirely new role as surgeons for stage 4 melanoma, because these therapies have now been improved and rapidly expanded and used across the country. And that cell therapy for melanoma, at least today, is TIL, or tumor infiltrating lymphocyte therapy. And this is a personalized autologous treatment that involves the ex vivo growth and expansion of tumor resident T cells and subsequent intravenous adoptive transfer of the cells after the patient's undergone lymphodepleting chemotherapy. And when they're infusing the T cells, they're also providing IL-2 to enhance the in vivo expansion of these T cells and augment the anti-tumor response. And so the very first step for this is a metastasectomy that needs to be performed by the surgeon, because at least today, the volume of tissue needed for this is such that you're not going to get it on a core biopsy. So you need the surgeon to be able to identify these lesions, remove them safely without causing significant morbidity, so that the patient can rapidly move on to a lymphodepleting chemotherapy course while they expand the TILs, and then intravenous infusion of the TIL with IL-2. And so, yeah, we're back to this IL-2 therapy again. And as you might expect, this is a really tough therapy to tolerate. but it showed efficacy. And so we ultimately ended up with a randomized controlled trial of TIL versus ipilimumab for patients with unresectable stage 3 or 4 melanoma. They had to have a lesion that was amenable to metastasectomy so that they could create the TIL. And they were allowed one previous line of therapy that they failed as long as it wasn't IPI. The primary endpoint was progression-free survival. And what this study showed was that there was a benefit in improved progression-free survival for those patients who underwent TIL compared to IPI. Further studies then showed similar efficacy, and as we got better at generating TILs and were able to move that production to a central laboratory, the FDA approved this therapy in 2024. And we're now seeing it pop up in multiple centers. But because it is a particularly toxic therapy, we are looking at ways to make this therapy a lot less toxic while still maintaining the same efficacy. And one of the ways we're trying to do that is maybe removing the IL-2 and leveraging some of these immunotherapy agents in place if we can. So studies ongoing for that. And so what I would posit is that actually the surgeon's role in stage 4 disease is most importantly right now tissue collection for the development of personalized therapies in advanced stages of melanoma. I think we will still continue to talk about the possible role for metastasectomy as actual treatment in carefully selected patients, but I think our big role right now is tissue collection. And so we started off with a surgically managed disease for which we'd already been slowly de-escalating surgery despite no effective systemic therapies, to a disease that requires a truly multidisciplinary approach given the number of therapies we now have available. Surgical therapy, immunotherapy, targeted therapy, and now cell therapy. And while the role of the surgeon's been changing throughout this timeline, surgery remains a key component of the treatment of melanoma, even in the era of immunotherapy, and our role in the multidisciplinary care of these patients is critical. And so I suspect it will be similar things in the future. While will continue to be needed for surgical removal and staging for early stage melanoma, tailored surgical therapy for advanced melanoma after neoadjuvant therapy, and tissue collection for the creation of personalized cell therapies, I suspect with that next effective novel line of therapy, we will be reinventing our role in the treatment of melanoma yet again. And so I thank you for your time and this opportunity, and I'd be happy to take any questions.
Welcome back.
Thank you.
Excellent talk. I was wondering if you could revisit this concept of the index node. I'm thinking that in a lot of peds oncology too, as immunotherapy is coming more in the neoadjuvant setting, what are the, you said that most surgeons were actually quite effective at finding the index node, but I'm trying to think through, tips for, could you just talk a little bit more about that?
Yeah, like the technical approach.
Yeah.
So it's a little bit dependent on institution and resources. So if you have a situation where your breast is fairly integrated with your multidisciplinary kind of non-breast care, it can be very convenient because you can ask the breast radiologist to localize axillary nodes the same way they localize the axillary nodes for a targeted axe dissection in breast cancer. And so if I had patients with melanoma that had that was draining to the axilla and they had axillary disease that was biopsied, we have them leave a fiducial, some sort of clip at the time of biopsy. They get their neoadjuvant treatment, and then they can localize it with other localization device you're using, whether it be radioactive seeds, Savvy, Elucent, Molly. There's a million of these. I think when it gets more challenging is when the breast and the cutaneous is truly separated, or it's in the groin. And so then you're needing to leverage, if you want someone to localize it for you, you need to leverage usually interventional radiology. And they may or may not have access to the same localization tools that the breast team has. And sometimes they're only able to leave you a fiducial. So in those settings, what we've been doing is we've gotten, or try to have gotten very good at ultrasound. So when the patient has their fiducial placed, we ultrasound them right then when the node is still big and it's easy to see, and we identify that fiducial. And with each time that we see them in follow-up, we ultrasound again, make sure we can still see that clip, make sure we still see that clip, and then use the ultrasound in the operating room to find that node with the clip in it. And then you can take an x-ray to confirm you in fact have the node with the clip in it. I have had times where I haven't been able to find that clip on ultrasound up front, and I've had radiology put a wire in the groin. I don't really love wires for this, but they don't have access right now at my institution to the radioactive seeds. So that's one of the motivations that we're kind of looking at other localization devices as well that can be used in other locations that don't have all the stringent regulations related to the radioactivity that the seeds have. So a few different approaches. It can sometimes require a helpful hand. And then also, if you wanted to try and do as much of this on your own, you know, the use of ultrasound. We do have clips in our clinic, so we as surgeons can place the fiducials too if it's a particularly large node and we know we're able to biopsy it ourselves, and we can place the clip at that time. So ultrasound skills can play a large role in how the ease of the coordination of this if you're not wanting to leverage radiology.
Thank you for the talk. Piggybacking off that question a little bit, what's the current role of ctDNA in melanoma? And based on the Prado trial design, could we measure it before and after neoadjuvant and see if it correlated with the index node pathology to potentially even not have to futz around with a lot of the index node issues?
Yeah, the corollaries for the MSLT3 are going to include the ctDNA work. ctDNA is not present always at super high rates based on the assays available right now. And so there are going to definitely be a large proportion of patients in this group that may not have a positive ctDNA to know, okay, they've really cleared because they never started with. And so I think improved assays is probably what we're needing first, but it is going to be an exploratory component of the MSLT3 study, at least based on the early discussions at the SWOT committees. So early yet, not quite there. We know it's prognostic, predictive, but not kind of as well as we do in breast, where we have clear evidence that in stage 4 it can be used for monitoring and adjustments.
Are there more questions? Otherwise, I'm going to make a comment. Anybody else have any questions? So I want to say thank you very much. And it was great to see you. It was really lovely to have you back, as Tuttle said. I think what I would like to encourage all of you on that side of the room to do is have some internal reflection when you walk out of here today, how you get from where you're sitting to where she's standing. Because if you're not impressed by her expertise, you should not be in this room. So when you walk out of here today, have some internal reflection. When you have cases that you put on M&M, take the time to look up the data. How do we get to that decision making? Why are we doing the things we're doing? Okay? It's really important. 10 years from now, or 15 or 17, depending on how many years you got left, that's where you want to be, right? Think about that when you walk out of here today. And thank you again.
Thank you for having me. This has been a true privilege.